Chris Burtin is a physiotherapist by background, working in academia. He's appointed as professor in the Department of Rehabilitation Sciences at the University of Hasselt, and he's also a researcher at Reval at the University of Hasselt. So Chris, over to you.
Thank you very much, Geert. Can you see my slide?
Yep.
Yes, and you can hear me well?
Yep.
Okay, perfect. And you can see me?
No, not yet.
No, you'll be able to see me now, right?
There you are.
Okay, perfect. So hello, everyone. It's a pleasure for me to be part of this spring webinar. I would like to thank Daphne and Geert and the organizing committee for inviting me for this interesting webinar. I think it's great to see how a complex disease as COVID-19 also brings together people from different disciplines within rehabilitation, right? Typically, we don't communicate that much. I'm originating from the pulmonary rehabilitation area, and well, it's good that it makes us discuss and talk. So I will talk about long COVID and its impact on daily life, with a focus also on patients with more mild disease. I don't think I have to tell you that COVID-19 is a complex disease, right? It is associated with a lot of symptoms that might arise in the acute phase, but also on the more long-term phase. And the fascinating thing is that the pattern is different in individual patients. Like every patient has their own symptom combination. You see that typically fatigue is the most prevalent one, the cardinal symptom, but also symptoms like headache, attention disorders, sleeping problems, dyspnea, muscle pain. There's lots of symptoms that might arise, and it's almost an endless list of possible symptoms. So in a proportion of patients, this seems to be present also on the longer term. And well, you can imagine there's a truckload of evidence coming in our direction at this time. If you haven't seen PubMed for the last week, for sure you're already behind a lot, right? Because these are, for example, 2 overview papers. We're already in the phase of systematic reviews and meta-analysis of everything we know on persistent symptoms that have been published in the last days. But actually, I think they mainly confirm what we know, that fatigue is the most prevalent, that there's a lot of symptoms involved. And what is also interesting, that it's really tough to predict whether somebody will develop chronic problems, chronic symptoms. The only, let's say, consistent parameters that always come back is the severity of the acute disease and the amount of symptoms. So in a way, that more severe acute disease and the higher number of symptoms in the acute phase might be a precursor of long-term symptoms, but it's surely not a one-to-one predictor. So let's have a look at some real-world data that have been gathered, and these are data from people that were in the hospital before in Wuhan. That rings a bell, right? So they followed these people for 6 months after hospital discharge, and well, I know this is a very, very big table, so I will not leave you alone with it. They actually made 3 groups. They looked at patients that were hospitalized that did not require supplemental oxygen, so with less severe acute disease. They looked at patients requiring supplemental oxygen, and they also looked at patients that needed more intense ventilatory support. Could be non-invasive or invasive ventilatory support. And they looked 6 months after hospital discharge, how these patients were doing, and they were comparing the different groups. And if you look at the symptoms, well, fatigue, sleep difficulties, and hair loss were the most prevalent symptoms. Again, with fatigue, it's the cardinal one, right? 81% in the group that has more severe disease, up to, let's say, 60% in the less severe disease. So you can see that there's a difference between the different groups, but I think it's important to realize that also the people who were, for example, not requiring supplemental oxygen, less severe acute disease, there was still a high proportion of these patients showing these symptoms. They also looked at the MRC score, and that's a score actually looking at dyspnea during activities of daily living. And also there they see 1/4 to 1/3 of patients actually showing that they had some sort of dyspnea during daily life activities. They also assessed the EQ-5D, which you might know, looking at different aspects of quality of life, showing that there's a relevant proportion of patients complaining of pain, discomfort, anxiety, depression. Also, some patients have even problems to walk around, clear mobility problems. And also there, the same pattern, a bit higher prevalence in patients with more severe acute disease. And they didn't only look at patient-reported outcomes, they also looked at, for example, a 6-minute walk test to assess exercise capacity. And they saw, again, 1/4 to 1/3 of patients actually showing here a 6-minute walk distance that was lower than normal. And what's interesting, they also looked at, let's say, more direct organ damage, for example, looking at pulmonary function. And I think the aspect of pulmonary function that is looked mostly at with patients with COVID is the DLCO here in the bottom. That's the diffusion capacity of the lungs. And there you see in patients with the most severe acute disease that the proportion that has still abnormal diffusion capacity is pretty high, right? Almost 60%, and clearly higher than what you see in the less severe groups. So there the difference between the groups seems to be more striking in terms of organ damage. But if you look at symptoms, if you look at impact on daily life, well, all groups seem to be affected. But well, this is a specific group. These are people that have been hospitalized. Lots of them have been in the ICU. These are people what the World Health Organization would call severe and critical acute disease. And in the next presentation, you'll hear more about that. But I think it's important that we also have to look beyond that hospital stay, right? We know now that there's something called the post-acute COVID-19 syndrome, or you can call it long COVID, or you can call it different names. There's still lots of discussion. There's also not a clear definition, but basically we have people developing long-term problems, and this includes young people, this includes previously healthy people, and this also includes patients with mild to moderate acute disease, people that were never in the hospital. Some people even had not too much complaints on the acute phase, but they develop these long-term problems that typically have this relapsing, remitting nature of complaints, in which at some point it seems to go better, but then they relapse again and they feel worse again, which is very frustrating, of course, for these people. So we did a research project in specifically these people that were not hospitalized. And we did a survey on about 2,000 patients that were not hospitalized. And these patients, they gathered in an online platform, including a Facebook group. So I'm the first to acknowledge that this is not well, that there's some bias, right, in selectioning this group, because all these people are actually in these groups mainly because they still had some kind of complaints. So it's a very selected group. But if you look at the characteristics, they're very young, and the mean age is 47 years. And 85% of them are also female. Looking at the symptoms that these people report during the infection and at about 3 months follow-up, well, you see if you compare the gray with the blue bars, that there's a decrease in prevalence of symptoms. But still at 3 months in these people, 87% was still complaining of fatigue, and more than 70% was still complaining of dyspnea. So many of these patients still had problems after 3 months. And this is another way to look at symptoms. I wanted to show you this graph from our PhD student, Martin, because I think it's some kind of a piece of art almost. But looking at the amount of symptoms that people are actually showing, you see that the amount of symptoms is actually decreasing over time if you go from left to the right. The median number of symptoms reported goes from an amazing 14 symptoms that are reported during the infection to still 6 symptoms existing 3 months later. So it improves, but it doesn't resolve. And if you look at the impact of these symptoms on daily life, well, if you look at care dependency, you see that about 60 to 70% of these people actually reported moderate to extreme problems to perform usual activities. 70% reported pain or discomfort during activities. 30% provide signs of anxiety and depression. Over 40% has basic mobility problems. So you see that this clearly had an impact in these mostly previously healthy people. And the care dependency scores that we get from the questionnaires are pretty similar to what we would see in chronic pulmonary or renal disease. So it has a striking impact in these people. It has an impact on their quality of life. It also has an impact on their work productivity. Most of these people were working. Only 60% reported, or 60% is reported to work less after 3 months, and much of that time that they spent working was unproductive. And I think what is really worrisome is that it also impacts on the future perspectives. 2/3 of these people is actually worried whether they will really fully recover on the long term. So they really fear the future there. And again, it's very important to realize that this does not happen in everybody who went through COVID disease. It's a very highly selected sample, but we're talking about thousands of people here, and that's an important message in itself. And if you talk with these people, I think it's important also to know what they are thinking themselves. And while qualitative research helps with that, patients typically experience the managing of symptoms and the accessing of care continuously as very hard work. It's a hard time, and it's hard to live with the uncertainty, the helplessness and the fear. They also stress the importance to find the right support, and especially the general practitioner plays a key role for them there. They want somebody who understands them, has empathy and supports them. And also, well, besides being listened to, they also have a need to be assessed. They want other people to search, to investigate what's going wrong with them. This comes from qualitative research. So in our last few minutes, few slides, I want to focus a little bit on, okay, what do we know already about increasing physical activity in these patients with long-term symptoms? From my background as a physical therapist, we have already quite some insights from research in patients that have been hospitalized, patients that have been in the ICU. Their general rehabilitation programs, including, let's say, moderate to high intense exercise training, can clearly have some beneficial effects. We don't have the top RCTs yet, but we clearly have some insights already. But we have very, very little guidance in the patients that were never hospitalized. And one of the publications that I like a lot, because it makes us think, is this one that has been published in the BMG a while ago, about providing a kind of an algorithm on how to return back to physical activity after going through COVID-19. And I'm not going to go through the details. If you're interested, it's a really interesting paper. You can find it online. But firstly, what they basically say is, of course, we have to do a medical checkup to see whether it's safe to go back to increasing physical activity levels and slowly going back to the normal situation. And once medical safety is assured, then they propose to go through different phases, and different phases with different goals and different intensities and durations. But what's interesting here is that they really take it slow. They say, okay, we need minimum 7 days at each phase. If it's tough and you have some consequences from going from one phase to another, maybe we should also consider to go back if it's needed. We only move up when specific criteria are met. And there's a lot of focus on assessment, on talking to the patients, on monitoring the perceived exertion, monitoring the mood of the person to see how they experience it, and to make sure that we're not exacerbating the symptoms, that we're not exacerbating the fatigue. Well, I think it's an interesting approach, because in some patients, we know that this happens. If they go to exercise training too fast, they might exacerbate the fatigue. And it's a careful approach. It's based on graded increase of intensity. And I'm also sure that it can go faster in selected patients. We have already some data, and it's also my personal opinion, what I see in some patients in our clinical practice. Well, some patients can go faster, and some patients really can go to that moderate and high intensity exercise for sure. But I mean, this could be a starting point. And it's all about, I think, talking to the patient. The reasons why we maybe want to go slow is that we don't really know still what the reasons is for long COVID. There's several hypotheses, right? Is it a persistent viremia? What's the role of the immune system? What's the role of the conditioning? To what extent do mental factors play a role? But what we know is that post-exertional malaise is frequently reported, and that physical activity might be a trigger of symptom relapse. Some parallels have been suggested with chronic fatigue syndrome, with ME, but well, this is clearly not yet evidenced yet. So I think we have to be very careful with making these kinds of parallels and look at it as a separate disease. I just want to end with 2 patient citations. First patient saying, okay, as much as I like enjoying walking the dog, it has a knock-on effect. But that effect is getting less and less, so the more I'm doing, the better I'm feeling afterwards. And I think relapses are just part of it. And there's another patient who says, okay, I've always been one of those people thinks, well, you just push through it, but this one you just can't do it. I think maybe I need to properly back off from as much daily activity as I can to recover from this. So I think just looking at the mindset of these different patients, I think we already have to adjust our approach on trying to improve physical activity in these patients, right? And number one, we might be able to progress faster throughout that continuum than in the second patient. So in the last months, I've always been ending my presentation with this last slide. I hope it'll be one of the last times that I have to use this one. I hope to see you all in real life soon. Thank you.
Excellent. Thank you very much. Thank you very much, Chris, for your presentation, linking the consequences to some therapy perspectives. And indeed, hopefully we can meet in person the next time. I see a couple of questions. First, a question whether there are any differences in the consequences of the COVID-19 variations. So the British, the Brazilian, the Indian. Is there any data on that you know of?
Well, I think it's a very good and relevant question, but I'm afraid that I cannot answer that one. I don't think we have any clear insights yet on the long-term consequences. I mean, be it on the short term, even we don't know a lot yet. So I think we'll have to wait for that information a while.
Okay. Yeah. Another question: have you been confronted with non-organic functional complaints after COVID-19? Is there any information on that or any reports you received?
Yes, well, I think it's complex to with non-organic, you mean like unexplainable complaints, right, that these people might have. I think in most cases, these people are, of course, on a let's say micro level, they are also not assessed fully. So it's sometimes tough to know what's going on. They typically have clearance from a pulmonologist and clearance from a cardiologist, let's say on a bigger level, that there's no big organ damage going on. But for the rest, we don't really know to what extent that there is still something physically playing. But for sure, I mean, it might be that some of these patients might end up in that category of patients. And well, if you listen to people that are working in that area, they also see that their waiting lists are getting bigger and bigger also for patients that need help without a clear explanation on what's going wrong. Yeah.
It's probably another reason why we should think of multidisciplinary or interdisciplinary assessments, rehabilitation teams.
Yes, and yeah, thank you for letting me make the most important point. Maybe that also in these, let's say, acutely mild patient, interdisciplinary treatment might be interested. And our healthcare system is not providing that, right? Typically, they don't have access to this interdisciplinary rehabilitation, but I don't think they have less indication for these kind of team efforts than people that come out of the hospital. Yeah. At least a proportion of them.
A last question. Most post-COVID rehab patients have more trouble in terms of desaturation, shortness of breath with moderate to high intensity exercises, e.g. walking, sit to stand, than with exercises of low intensity, like riding a bike. Is there any explanation or guidance for the best rehab approach?
Well, I think that's a very good question. It might also depend on what you want to reach, right? If you want to have optimal physiological effects, if you have patients that are clearly deconditioned and you want to reverse the deconditioning, it might really be important to have a minimal intensity to also be able to change that. If it's about picking up a more active lifestyle again, then lower intensities can also be important. So I think it's really important on what the aims are for the patients. But what I think is that patients that really still get desaturation also on the longer term, well, these are the more complex patients, and probably in these patients there's some kind of an organ failure also still in place, and that these people might also better end up in a supervised interdisciplinary environment.
Mm-hmm. Complex and still poorly understood phenomenon, long COVID and COVID consequences. Okay. these were all the questions. Thank you very much. And thank you very much, Chris, again for the presentation.